All right, folks who are watching on YouTube, you're behind the scenes with me and or David Chase and I, and we're just about to go live. So stick with us. All right, Dave. Now that that is out of the way, we're going to go live to our studio audience. All right,
All right,
there
cool.
we go. Curtain's going to be pulled up. Three, two, and one. All right. Greetings, everyone. This is Eric Glazer. Welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but most importantly, unearth bright spots, successes at health plans, employer groups, providers, and various other health related companies around this country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if these ideas shared on our show can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. I highly recommend you subscribe to the Bright Spots in Healthcare podcast. It's free. Just since October, we've had just an incredible series of plan and provider roundtable discussions. We have covered the consumer voice, the heart of your healthcare strategy. We've talked about innovations in physician engagement, the digital divide in healthcare and how to reduce that, how to embed mental health into a primary care setting permanently, how to reduce health inequities, the future of primary care. I could go on and on. These leaders at health plans and providers that are in these discussions share all kinds of bright spots. And by way of our live audience, I could tell you that the last 2 months, our net promoter score, and those of you who are familiar with NPSs probably could gauge this, we have been over 80. So that's almost unheard of. I think that could help me almost guarantee you that it'll be time well spent to listen to these episodes, whether you're walking around the house, walking outside, going for a run, in the car, whatever you do. Just go to your phone, go to your favorite podcast app. It could be Apple, Google Play, Spotify, whatever. We're everywhere. Type in Bright Spots in Healthcare. It'll come up, click subscribe, and boom, every week you'll get new episodes with all these great experts that come onto the show and share their stories with you. You'll get them right on your phone or tablet. And do us a favor, if you like it, please give us 5 stars and maybe put in a comment that really helps with the search engine optimization. Today's episode is sponsored by one of our best partners, Revel Health, now merged with Novu Health. They'll be coming out with a new name soon. Those of you have heard me pontificate how sometimes when we get into a big echo chamber in healthcare, especially around things like consumer engagement, Revel Health is doing an taking an unbelievably novel approach through sophisticated yet cost-effective technology in leading healthcare organizations, consumer engagement strategy and programs. I will tell you a little bit more about them later on the show, but you could check them out at either novu.com or revel-health.com. So thanks to those guys for supporting our programming. And incidentally, we're already planning our 2021 programming. Q1's almost full. If your organization wants to reach payers and providers, and they want to amplify, you want to amplify your thought leadership, improve your content marketing, enhance your networking and lead gen, shoot me an email. Let's talk. eglazer@sharedpurposeconnect.com, or you could message me on LinkedIn where I'm fairly active. Would love to talk to you about how we could partner around programming next year. All right, today's episode is incredibly thought-provoking. It's going to be jam-packed with bright spots. I'm really stoked to have with us David Chase today. David, and I'm sure you've heard of him, but in case you haven't, he leads the vision for Health Rosetta, which is they empower community-owned health plans. They provide a blueprint and platform that powers the health plans of your dreams. High quality, trustworthy, local, affordable care that you have thought may have disappeared forever from caregivers that you know and trust. He is also a best-selling author and a consultant for the Fox hit drama The Resident, as well as a TED Talk presenter. He uses all of these platforms to inform, empower, and activate a broad grassroots movement designed to restore hope, health, and well-being to our communities. Dave recently received the Health Value Awards Lifetime Achievement and for Health Benefits Innovation at the 2020 World Healthcare Congress. And last, but certainly not least, recently released his latest book, Relocalizing Health. The future of health will be local, open, and independent. And that is the theme for today's conversation. So, Dave, welcome to the show. And what inspired you to write this latest book?
Just the momentum that we were seeing, and that people are taking a hold, right? And in some sense, people, when it comes to healthcare, have kind of had a renter mindset, and it's taking ownership and then seeing what's working, right? In terms of, there's lots of challenges around the world, around our country, and the thing that I get into in the book is draw some analogies that we can apply into healthcare, whether it's in food, whether it's in craft brewing. Maybe we'll talk about that. There's some really neat examples that even in the face of some pretty entrenched systems have had huge success, and we're starting to see that in our arena. And so wanted to tell that story. When I wrote my first book 3 years ago, the successes I was talking about were ones that we kind of modeled our effort on. The new successes are ones coming out of our community, and it just shows the momentum that's already been building.
Awesome. Okay. First of all, I have a follow-up to that. I'm going to read an excerpt from your book. Just maybe speak up a little bit.
Sure.
I'm hearing you a little bit. I don't know what our audience is feeling. And incidentally, if you have sort of feedback for us, you could certainly use the chat window. Sherry Kills, our producer, will be posting links throughout the show through that chat window. But if you want to ask Dave questions, use the Q&A module, not the chat. So it's much easier to manage the Q&A module and integrate questions into the flow of the conversation. So that's at the bottom of your Zoom interface. I'm pointing to my second screen because that's where it is for me. But definitely click on that, ask questions. We should have plenty of time. We've expanded our docket. I don't know if we'll use all 90 minutes today, but we have plenty of time. And those of you who are listening on the podcast, we'll probably break this into 2 episodes. So this will be part 1 of the 2-part series with Dave Chase. All right, Dave, I'm going to read for you some of your fine handiwork, and I want you to react to it. Healthcare isn't expensive. Pause, dramatic pause. What is expensive is profiteering, price gouging, and edifice complexes that prioritize building Taj Mahals over disaster readiness. Discuss.
Yeah, I mean, when we think about healthcare, who actually delivers healthcare? Who are the value creators, right? It's the clinicians. The clinicians are only getting 27 cents of every dollar ostensibly spent on healthcare. So that's what I mean. The actual care part isn't expensive. We could take all of their pay to zero and we would still have a big problem. And so that's really the point there, that we pay them appropriately. They do amazing work. Let's get rid of profiteering, administrative bloat, price gouging, some outright fraud, and healthcare becomes quite affordable. And that's really a lot of the story of the book, is the organizations have done that. It's not some fantasy. They're doing it. We've seen it all over the place.
Okay. So the core of the book, it talks about how we would be better off rather than relying on the Fed or large commercial insurers, that we'd be better off we took a much more local approach to healthcare. So not even at a state level necessarily, but more specific, focused on municipalities and towns, which I think makes sense. So how are you defining localism? Help us understand that.
Yeah, I mean, I take it hyper local, at 2 different levels. So there's one, governance of health plans. That's one piece of it. The other piece is, what's the ultimate local? Our home, right? That's actually where health starts. And recognizing most of care happens in the home, and most care, we've certainly seen during COVID, can happen in home. It's really just an odd distortion of our reimbursement system that we force people to come in. And you talk to docs and they'll say 2/3 of the time, you don't need to come in. I just force you to come in because that's the only way I get paid. Now, some of that's changed during COVID, But that's one level of it, and that 80% of health outcomes are driven by things outside of our healthcare system. And we really think about the totality of health. Now, when it comes to actually the health plans and healthcare delivery, that's where, again, most of the care is local. And you take a county like the one I live in, about 250,000 people. So all in, all ages, we spend about $2.5 million or $2.5 billion on healthcare. At least $1 billion of that is extracted out of our local economy. And for something that's what's more, fundamentally local, what's more local than an interaction between a doc and a patient, right? I mean, and that can be in person, but that also can be around their community. And docs, when they do their best, nurses, when they're at their best, they know the overall conditions that person lives in. And that's a key part of localism as well.
Okay, I'm going to let you react to, it's not a question from one of our audience members, but it's a comment, and I'd like you to react to it. Healthcare is actually sick care. As a physician, I'm not paid if my patients are healthy. I'm paid the sicker they are.
Right. Great example of the distortion in our system. You actually hear some stories about how in ancient China, docs were only paid when patients were healthy and they stopped getting paid when they're sick. That might be a little extreme, but if you look at the organizations that are performing the best in some of the most difficult situations imaginable, whether it's the Nuka model in South Central Alaska or Oak Street in South Chicago or Rosen Hotels, they're paid prospectively, right? So they, particularly for primary care, it's silly to be paid, like a good year is when there's a bad flu. That's pretty odd. And so when you remove that distortion, you let doctors be docs and let the rest of the team do well, they do right by all, we always put things through the quadruple aim filter. Is it great for the care team? Is it great for the patient? Does it lead to better outcomes? Does it lead to lower costs? And you look at those scenarios when they're paid in the right way, then you don't have that perverse incentive of you're paid more when they're sicker, or God forbid, we turn hospital CEOs into hotel general managers and like they're paid more when the beds are full. Like that's bizarre. And we need to, of course, get rid of that.
Yeah. So I want to, we're going to get into bright spots, folks, in a moment. And you heard Dave just allude to Rosen Hotels. That's going to be an interesting story he's going to tell you, but I'm going to hold off on that for just a moment because I want to get into some other cool parts of the book as it relates to localizing. And so earlier today, I teased today's episode around what can healthcare leaders learn from the beer industry. So I want to talk, there's a quote from one of your friends and colleagues, Chris Brookfield, who alludes to the fact that the answer of the healthcare crisis may be found in the beer we drink. And I know maybe I'm stretching his meaning a bit, but explain to us what we could learn from the beer industry and the potential positive impact localism can bring to healthcare.
Yeah, I mean, it's a great example where the craft brew industry has about 21% market share, a dollar share of beer sales now. And there's two mega beer companies that dominate the market. So pretty tough scenario. And what they have found is that they're radically open with each other. There's a spirit of collaboration. And I think I've drawn an analogy between direct primary care docs and craft brewers, where they get together, what's working, shared legal documents, shared marketing. Like this time of year, you'll see them actually put together 6-packs where it'll be from 2 different independent organizations, or they'll have these events where they'll come together and kind of mash it up. And so what you find is, and really the common thread is, tends to be very local, very open, and very independent. And so they find common cause and lift each other up because, in a sense, they're all, in the same fight against sort of the, monsters in their industry. And so that's kind of how I think it applies here.
Yeah, I really like that. I was actually having a conversation with a chief medical officer earlier today at a health plan in your neck of the woods, talking about this very dynamic. I would say this though, and probably I'm going to ask a question on behalf of the audience that may be thinking about it and thinking a little bit as a skeptic. Okay, going local may be great, but how do we maintain access to quality of care when we already have a shortage of PCPs right now, and we already have this dramatic shortage, I dare say, crisis around mental health practitioners? So if we're going to get really local now, a lot of folks may lose access. So how do you reconcile that?
Yeah, I mean, there's two important issues. The way you reconcile it is be local when it makes sense to be local. If I've got some, rare cancer or some really complex neurological procedure, you know what? I'm probably going to go to Virginia Mason or Mayo Clinic or some place like that. That may mean traveling, plane or just drive a little ways. But the everyday stuff, um, so there's two related issues. One is when it comes to primary care and mental health. Mental health is something where you don't need to lay on hands. And there's
Sorry, say that again. Mental health is something that,
you don't need to lay on hands,
right?
right? So you can do that generally quite effectively. I mean, certainly video interaction, but some can be done via apps, via asynchronous things for more kind of run of the mill, if you will, mental health issues. More complex stuff may require inpatient or in person, but most stuff, and particularly like again during the time we're in, there's a lot of mental health challenges that people have, and so that can be fine for that. Now, when it comes to primary care, the reason we have the shortage is we've made life miserable for primary care docs in this hamster wheel fee for service model. And so it's no reason, like, there's probably not lots of people signing up to be, I don't know, clearing landmines from former war fields. Like some people would do that, most people wouldn't. And so there are plenty of primary care docs happy to come back. And also the other thing that I wrote a whole article on this, there's a whole set of solutions. One, don't make it miserable. So there's people who come back and that have maybe specialized, they were internal medicine docs and they've specialized. But you use a full-blown primary care team. Just use the docs for what docs are best at. Everybody practices at the top of their license. We'll probably talk about some primary care models where in a fully actualized primary care model, you have woven in not only the doc, but nurses, dietitians, health coaches, mental health, physical therapy, and consequently in those fully actualized primary care, they can address 90% of the issues people come into the healthcare system for. Doesn't all have to be docs. And so that, coupled with some technology, coupled with some creativity, you get over that issue. And we just have to kind of rebuild that brick by brick. And that's what's going on right now.
Okay, well, let's get into some of these examples, right? So we talked about rows in hotels.
Yep.
So some of these organizations that we're going to talk about now are actually doing things or are applying everything that you talk about in your book into practice, and in essence, validating your thesis. So
Yeah.
Let's learn a little bit about employer benefits at this small hotel company in Orlando is it called Rosen Hotels and Resorts, right?
Yes. Yeah. Yeah. So the main thing that makes them unique is they've just been doing it longer than anybody else.
Give us a profile of who they
Yeah.
are.
So they're an independent organization. Actually, when they started, they were about 500 employees. Now they're over 5,000 employees, so they've grown. They have benchmarked versus their competitors, and they're in Orlando. And they cumulatively saved over $400 million versus their benchmark competitors by saying, wait, like, why are we paying more and getting less every year? That doesn't happen in the rest of my supply chain. And our employees are our most valuable asset. And so we're going to act like that. And so they just started on this journey bit by bit. And really the foundation, again, is primary care. And despite the fact that they have a significant health burden, 56% of their pregnancies are categorized high risk, just to use one example. Despite that,
Why is that?
it's they have a lot of Haitian immigrants who've come with HIV, TB, they have advanced maternal age, those things that basically contribute to higher risk. And it was relatively early on in their journey, even after they had primary care, they were dependent on the health systems doing that and doing the follow-up and the OBs, and it just wasn't happening. So they more actively engaged on that. And they avoid the vast majority of preemie babies. And a lot of those times, those are avoidable situations. And so they also, again, people have physically demanding jobs as maids and maintenance workers. You'd think they would have big opioid issues. Most common reason people get prescribed an opioid, number one reason for disability is lower back pain, but they not only bring PT into the clinic and chiropractic, but they go out into the workforce and do that. So what that allows them to do by not squandering money on care that doesn't work, by doing prevention, and really just doing everything possible in the primary care setting, that allows them to have an incredible health benefits package, but it doesn't end there. They subsidize healthy food. That's a good thing. Hippocrates said, let food be thy medicine. They also pay for their employees and their employees' kids' college education. Guess what that does to turnover? They got a sixth of the level of turnover. And if that wasn't enough, what they have done is adopted a once crime-ridden neighborhood near them, and said, we're going to invest in kids in education. And they so far have funded 450 college educations. During that time, I actually have an update since I wrote it in my book. Crime actually went down 78%, high school graduation rate. About every other year, it's 100%. It's darn near 100%. It's just amazing. And this is a community, kind of first quartile income, where the average 4-year degree completion would be 9% normally in a community like that. They have 78% 4-year degree completion. Some people are getting 2-year degrees. So it's really an amazing story end to end. And the entire investment of that community that they really invested in was less than 5% of that delta between what they spend and others who are squandering money spent. So it's very affordable.
So Dave, let me ask you, why were they able to do this? Was there a visionary there? Are they the right size? What makes this, everyone knows Orlando. No one's probably, or very few people have heard of Rosen Hotel. Why them?
Yeah. I mean, it really just comes down to your hardcore entrepreneur, son of immigrants, they watch every penny. And he just started, it was just fundamentally a mindset shift, where it's what's going on here? Just started asking questions, and then ultimately said, you know what, we can do a better job than them of managing risk. We manage in other areas. We'll figure it out. We'll hire people who know it. And so it was really the key difference was just mindset shift.
And was there a healthcare visionary or the CEO or owner? Where did this all?
Yeah, I mean, the CEO, owner, founder, he, Harris Rosen is his name. He didn't know anything about healthcare before. He just was frustrated. And so he did hire Ashley Bacot, who he is kind of the risk manager for their organization. And one of the creative things that they've done is they take what are cost centers for most businesses, not just health benefits, and they turn them into profit centers. So they not only have this captive risk management group, but they offer their, basically benefits consulting to other employers like school districts near them. Okay. But they just took hold of it, hired a leader for the clinical side, Kenneth Aldridge, and then he just started building it and just started problem solving. The example I gave around preemie babies, that happened after there was a preemie baby. What is going on? Again, if you had, leaks on the golf course over and over, you're like, wait, we got some problem with the pipes. We need to maybe dig up, the pipes and see what's going on. They just did that in healthcare. And most people just don't do that and are led to believe it's like rocket science to figure it out. And it's like, yeah, it's not simple, but it's not rocket science either.
Right. So folks, I'm going to move on to another example I'm going to ask Dave about. If you want some follow-ups on this particular bright spot, throw them into the Q&A. I'll circle back. I know folks sort of are thinking maybe they forgot about I'll circle back, but I'm going to move on. I know sometimes we are reluctant here in the US to look outside of the US because we think sort of our healthcare system is unique. And in some ways, maybe the way it's funded is unique, but the reality of it is some of the inherent challenges we face are similar all across the world, especially in first world countries, that's for sure. So could you tell us about a bright spot that you've looked at around localism outside of this country and explain a little bit why it works and why it could be applied here?
Yeah. Jönköping, Sweden is a great example of that, where, people tend to perceive, a country like Sweden as having a monolithic nationalized system. And they do have national guardrails, but essentially their healthcare is governed at the equivalent of like a county or frankly like a school district or fire district, basically like a health district. Jönköping, I think, has got about 500,000 people, and they recognize that they look at the totality of health. Health's a lot more than just hospitals or even doctors' offices. They recognize, and in their world, they're addressing all ages. So I'll just use an example, with seniors, where although it extends beyond seniors, is somebody may, in a U.S. context, have a primary diagnosis of diabetes, hypertension, something like that. What they do, and actually the NUCA model in South Central Alaska is actually very similar thing. So you can have a similar example in the US. The primary diagnosis is loneliness. It's dependence.
Yeah.
And that's the real issue. And so you can try to address it with medication, but because they're given a pool of money for health and well-being, they say, well, why don't we create, a senior center? Why don't we create active, adult education? Why don't we do some cross-generational things between preschoolers and seniors? And it's great for both parties. Not everybody's got, in this, society, even there, not always our grandparents around or in the same locale. So things like that, where if you keep people out of the hospital, if you're not operating like a hotel general manager, that frees up all kinds of money to do these types of things. And so that's what's really inspiring about these models as they look at the totality health. Certainly that's what Rosen did, right? They know that if you give your workforce the opportunity to get a college education and better themselves, that's very motivating for them. And they're going to do right by their family and by their own health. And as a byproduct, they're going to be a dynamic workforce that doesn't want to leave and are really happy to be there. And I've stayed at their hotel. You can tell, even if you weren't knowledgeable about their health plan, like this is not your average workforce. People love working for that company.
Yeah, that makes a big difference. I'm going to grab a question from the audience in a moment. Very quickly, I want to briefly pause and tell everyone a little bit more about our sponsor today. Today's show is sponsored by Rebel Health. They work with health plans, ACOs. They take a much more sophisticated approach to focusing on an individual's needs. So think of it as an individualized approach to population health. If you have ever talked to the most sophisticated ad agencies on Madison Avenue, the ones that represent the brands that you know and love, Toyota, Coke, Apple, you name it, they take a much more sophisticated approach than most of us do in healthcare to identifying consumers and then understanding the consumer's values well enough to truly influence behavioral change. We in healthcare have not been that sophisticated in our marketing to our consumers, our patients, our members, who are at, let's say, the highest risk of costing the most money. And that is until now. Rebel Health is taking an AI approach tied to marketing expertise to allow you to not only segment your patient population, but and not only to create personas for your population, but to create dozens and dozens of specific personas and truly take an individual's core values to help them modify behavior tied to their healthcare. You could check them out at novu.com or rebel-health.com. I believe they're one of the latest bright spots in healthcare and could really add value to many of you folks listening today. So check them out. I want to take a question from the audience, Dave, and then I want to get into sort of the reconstructing of healthcare topics that you cover in the book. We have one audience member asking about how do the benefits of continuity of care persist in an quote open unquote environment?
Well, I could interpret that a few different ways, but since we were talking about kind of the openness with the craft brewing and connection to primary care, that's really the heart of it. Is it's a relation, not a transaction. And that's where, if you really want to understand what's going on with a patient, you find that out via a relationship, an ongoing relationship. And when you have the right economic model, then you have the right model to really ensure the continuity of care. I personally experienced this myself with my dad through his 5-year Parkinson's journey. You can't turn Parkinson's into unicorns and rainbows, but they do recognize that that's a long journey. The family's very important. If you can keep them out of the hospital, that's going to be better for everybody. My dad didn't spend one day in the hospital through that journey. A lot of the continuity of care was through the health coach. We had the doc, great doc, don't get me wrong, but they were, issues come up, and stuff hits the fan. And so having somebody that's literally on a cell phone, you can call them or text them or email them, and they're going to be right on it. One of the times when my dad fell, it wasn't, he didn't break anything. It was like, man, the cavalry came. It was like occupational therapist, physical therapist, a little bit of home care and a little retrofit in the home, and like, boom, they were there. So that's part of what I would call continuity of care. It's looking at the activities of daily living that he was going to be way happier being at home with my mom than being isolated in a hospital.
Good. One more question, a little bit self-serving. Those of you who are regular listeners know that I have a day job at a telehealth company. So I'm going to ask this. Do you feel telehealth reimbursement amounts will remain constant after the pandemic has ended?
Constant from where they are right now, where they've removed the...
Let's assume that's what...
Yeah. Well, they should. If anything that can be done via some telemeans, again, it can be video, could be a text message. Could be remote monitoring. There's a variety of things. We should just do what's most effective. And if you remove the distortion of paying different amounts, you just do it, right? You look at, some of the great Medicare Advantage plans, they don't have to have a reimbursement code to remotely monitor a congestive heart failure patient with a wireless scale, or for that matter, to replace shag carpet or air conditioner, coming into a heat wave. They just do what will optimize well-being. So I sure hope so. Let's just pay for value. And in a lot of cases, the telehealth is just a function, just one of the modalities, and it's included in a broader payment that is paid either by a private or, government payer.
Okay, great segue into sort of how to reconstruct healthcare. I'm going to take another excerpt from the book. Transforming healthcare requires redoing health insurance to support the healthcare system we want, not the one we've got. Okay, how do we do this?
Well, first of all, recognize about every 50 to 70 years, healthcare fundamentally transforms the way the delivery model works. We are overdue for that.
Can you provide a retrospective example of that?
Yeah, I mean, basically Medicare was kind of in the U.S. and some extent earlier with World War II. Like that's when the National Health Service for Britain came in. That's when the employer-based system came in the U.S. And then 50 to 70 years before that was sort of germ theory and antibiotics and more evidence-based medicine and stuff like that. So it's those type of large scale changes. And we have a generational shift happening, where the largest generation in history are millennials, not boomers. Sorry, boomers. Um, but they require different things, expect different things. The world has changed, and obviously we're seeing that in a big way during COVID. But well before that, I mean, you have a supercomputer in your hand. There's a lot that can be done there. And so that's kind of some of the backdrop. Probably one of my favorite quotes is a Buckminster Fuller quote that says, you never change things by fighting the current reality. You make a new model that renders the old obsolete. And, the analogy I often draw with between healthcare with is the built environment, because the built environment, sort of like healthcare, incredibly local, incredibly entrenched. And over the last 20 plus years, it's radically transformed because of the US Green Building Council came out with this LEED certification, and they came out with a new blueprint. And over 20 years, that got fully mainstreamed around the country. And what LEED didn't do is say, oh, let's just put recycle bins in polluting coal-powered buildings and call them green. I would argue a lot of what passes for innovation in healthcare is the equivalent of putting recycle bins in polluting buildings. You do need to do a reset. And it's not like, hey, everything's going to change in a year. It's just there's certain locales, Tyler, Texas, and in healthcare. But if you look in the built environment, places like Portland and Denver and Seattle were early adopters of it, proved out the ROI, and then it kind of rippled locale by locale. And so you see that with primary care we were talking about earlier is getting fully rebuilt in Tyler, Texas. I hadn't even heard of Tyler, Texas 2 years ago, but I had to go see it for myself. Those type of things where you rebuild from the ground up, and it starts with recognizing, there's no well-built healthcare system in the world not built on proper primary care. So that's at the foundation. And then you get a drug program and you don't allow all the PBM shenanigans that go on. And then you're like, okay, what's a fair way to pay hospitals for great care? And it's just a reset. And what you see in a lot of the efforts today, it's just kind of putting lipstick on pigs and paving cow passes. Like, guys, you need to just do a reset. And I get that reset will take a while to ripple through, but that's what we see happening, particularly in the mid-market. I would say like the sweet spot is mid-market companies, sort of 50 to 5,000. The workforce in the COVID era, we'd call them essential workers. They're sort of the working and middle class. They're sort of the bedrock of a lot of our communities. Often 30 to 120 minutes away from metropolitan centers, and they don't have the luxury to sort of be wasteful in their spending. Organizations like a Rosen, where it's employee stock owned or family owned, or these type of some cooperatives, they're like, we just need to take control of this. And so it's not that complicated, and a lot of times we just keep layering on fix upon fix when a lot of them is just kind of band-aids.
So obviously the foundation of any radical improvement in healthcare I know you believe, and I believe, is rooted in primary care.
Mm-hmm.
So I'm gonna grab another excerpt from your book, and I want to get into a specific bright spot at a state that most people won't think of as one that is maybe pioneering a new way of thinking about healthcare. Here's the quote: "Investing in local primary care practices and physicians are critical. There is no high-function healthcare system in the world not built on it, and U.S. primary care must be rebuilt from the ground up." So How should we be rethinking primary care, and provide us with a cool example?
Yeah. Yeah, a great example. I mean, Rosen, we talked about earlier, did this, but let's talk about the Nuka model in South Central Alaska. 15, 20 years ago, they were really struggling. This is an Alaska Native population they serve, checks all the difficult boxes you could imagine.
Could you let everyone, before, like, a little
Yeah,
profile on Nuka in general? Because I'm
yeah,
guessing we don't have a lot of Alaskans on the call right now.
yeah, for sure. Now it's an Alaska Native owned organization that they manage, their sources of payment are from the Indian Health Service, Medicaid, Medicare. They have, really at the heart of it is a fully actualized primary care, but it's a full blown health plan at the end of the day. And I think they 50% own the hospital, cover about 55,000 lives spread over, I think, 1,500 miles, and really, challenging setting. I mean, they've done some really inventive stuff on telehealth, right? Because some of these small villages, there's not even a nurse in some of these places. So they've had to be very inventive and, teach people who, basically become a medical assistant and can kind of do the things at a local level that need to be done. And what they did was they call um, their patients customer owners, and that really reflects their mindset. And they also recognize that most, probably for 2/3, 3/4 of health outcomes are driven by lifestyle disease. And guess who controls what happens there? The patient and their family, right? It's not, when you talk about, procedural thing in a hospital, you can apply Lean Sigma, Toyota, manufacturing. That's great. Love it. But when you talk about the nuances of somebody with pretty significant mental health issues, diet, lifestyle issues, they really need to become local trusted members. And so more than half of their workforce are Alaska Native people. They provide career paths for that. And going back to that fully actualized primary care, that's what they're doing. They've got the doc, the nurse, the pharmacist, the physical therapy, um, uh, behavioral health, social work, right? All that stuff is tightly woven in. And, it used to take a couple months to get in for appointment. They guaranteed same day access. It was brutal for about 2 months, when they had to work through that. But they did work through it. And so they established a trust, and really understood it's the environment people live in. Going back to the example from Sweden, where, yeah, somebody may present as diabetes and hypertension, but it's really dependence and loneliness and maybe substance abuse, whatever, right, that is driving that. And it's a messy human stuff, the life sucks disease, that many people have. And it's getting at the root cause of that. And they're the only two-time winner of the Malcolm Baldrige Award in the entire healthcare industry. You can go to their website, you can see their outcomes. Again, a really tough setting. Some of the best HEDIS scores, some of these different measures of performance. They just do an amazing job, and they don't stop. They just keep working at it, because it's an ongoing journey. And they've come a long ways, but they haven't stopped.
Great stuff. Yeah, definitely. Listen, this is what the show is all about. So I'm loving these examples.
And they're spending half, by the way, what they were spending before.
Yeah, folks. So if you want to learn more about this case study, I told everyone who's on the show live here, if you want a copy of Dave's book where he provides an entire appendix with all these case studies, we're going to put up a poll here. And anyone that wants a copy of the PDF version of the book, we will have Dave send you a personal email with the PDF, and you could get access to that, no cost or anything, and be able to really distill down into some of these great stories that he's sharing with you today. So I'm gonna have Sherry in a moment put up a poll. I'll just be yes, no, click on yes. Those folks will get an email from Dave with a copy of the book. If you are listening to the show on recording via podcast, why don't you go to sharedpurposeconnect.com/chase. and there'll be a small form there. Just quickly fill it out. We'll forward it around to Dave. We'll get you a copy of that PDF as well. sharedpurposeconnect.com/Chase. We'll do that for you. So thank you in advance for doing that. If you want a copy, also, folks, you'll be receiving, if you haven't already, in your inbox, our traditional feedback survey. I mentioned NPS scores. All the topics we cover are driven by you, the audience. All the refinements we make in the show are from you, the audience. I only am able to reach and get your feedback by way of this survey in large part. So please take it. We listen. It takes about 2.5 minutes, according to SurveyMonkey, to complete, and we read each one. I read each one. So please do that, because if you don't, I'm going to continue asking you to through email. And I know I've already spent some real estate in your inbox already. So let's try to save the world from eGlazer in the inbox and fill that out right now for us. Thank you in advance. Okay, let's stay on this topic. Healthcare system changing the world up in Alaska. What if we came down to the continental US and talked about who on a health plan side is rethinking primary care in, maybe not as effectively, or I don't know, I don't want to put words in your mouth, but who else is changing the paradigm here on the continental US from a plan perspective?
Well, it relates to the example I mentioned with my dad. So my folks, now just my mom, because my dad's passed, were on a Humana plan. They have been quite proactive about partnering with some of these next generation primary care organizations like Oak Street. Iora Health is the one that my parents were in. Fantastic organization. There's organizations like ChenMed and a whole Caramora. There's a whole host of them. But Iora and their partnership with Humana is a great example where with Medicare Advantage, going back to the comment earlier around getting paid the sicker they are, that just flips the model. They do better the healthier people are. So they did well by not having my dad go in the hospital. Given the set of events that transpired over his 5-year journey, probably saved the taxpayers, $500,000, maybe less. And so they get some of the benefit of that, because they kept people out of harm's way by not getting in the hospital and preventing that situation from ever happening. And that was a beautiful thing for him and my mom and myself and my siblings to not have him go into that setting, because about half of Parkinson's patients also get dementia. And it's very difficult, right? And it was never easy, but it was made much easier by having them at home, having a great model that, to their credit, Humana has found some of these great primary care organizations to partner up with on these Medicare Advantage plans.
Yeah, it's a great story. My mother-in-law had the same exact disease with dementia. And I don't know how people do it. Unfortunately, I knew enough to be dangerous around healthcare, and we kept her out of the hospital as much as possible. And I think that was a big difference.
I mean, there is a retraining, right? I mean, just to give you a little anecdote, early on, first of all, there's a whole story on trying to get an 80 and 82-year-old to change their doctor and health plan. Not easy, but that's a whole other story. But early on in that, I would come down every week about an hour and a half away from where my parents live. And my mom and dad knew I was coming, but I got into their house and my dad was laying on the floor in the living room. That's not his normal place to be. He'd obviously fallen. And I'm like, I got him situated and I'm like, Mom, what's going on here? Why was this happening? Well, Dad fell and I couldn't lift him up. And I'm like, have you called Iora? No, kind of like, I don't want to bother them. I'm like, Mom, like, this is why they're there. And as I mentioned earlier, once we kind of sounded the alarm, then like, poof, they were really helpful. But it is different, right? When my dad got diagnosed with Parkinson's, for all intents and purposes, my sister, who's a marketing consultant, kind of quasi-diagnosed him, not because he had trembling, but something was awry, and went to a specialist. The specialist diagnosed him with Parkinson's, basically gave him a couple prescriptions. You got Parkinson's, see you in 6 months. Good luck, sucker. Just I'm editorializing at the end, but that's kind of what our system does. And once I got them shifted over, there was a warm embrace by the Humana Iora deal. And guess what? Their doc he was a geriatrician. He dealt with lots of seniors with Parkinson's. He knew the general contours of the journey that we were going to embark on, and could, allay some of the anxiety we had. And that was good for everybody ultimately.
Let's stay along this path. I'm going to mix up the order of some of the questions I had planned, and let's stay with specialty. What about specialists? Because we talked a lot about primary care, and I'll back up. We'll get back. I'm going to really talk about wellness, because you guys have strong opinions on wellness in the book, right? But let's talk about specialties and centers of excellence, and where you think specialty services should move in this country, and maybe even provide us with a bright spot there.
Yeah. I mean, obviously they're vital in the system. Having said that, a lot of times specialists have become primary care because we've undermined primary care payment in that model. So a lot of cardiologists are kind of doing quasi primary care. That's not what they're best able to do.
And medical oncologists, yep.
Yeah, same thing. Like you said, oncologists. I mean, you go through any of these things, endocrinologists, you name it. And so really extending on that, have everybody practicing at the top of their license and do what they do best. And I mean, you got, orthopods who are being team doctors for the local professional league, basically for marketing purposes, when most of them just want to be doing surgery. And so you work with the high quality ones who are willing and embrace coordination with primary care, because they're going to be that long-term point of continuity. And they're phenomenal, right? You want them when there is something dramatic. But you want them as a part of a team. This sort of Wild West cowboy thing, everybody. I mean, Rushika Fernandapule, who's the founder of Iora, I mean, he told me a story, and he told me lots of stories, but one of the stories he told me was a patient with basically pretty simple health issues. It was kind of diabetes, hypertension. And by the time he got to her and her adult daughter, she had 12 different specialists. She was on 25 different prescriptions, and she was in and out of the hospital. And basically, they came in that first appointment with like a Target, shopping bag full of all the different prescriptions, and poured them on the table. And it's like his head, his eyes practically popped out of his head. It's like, oh my God, this would kill a horse if you took all this. And they're like, how are you managing this? Well, basically pour it all into a bowl, kind of like Halloween. And every day we grab 5 and we pray, and my mom takes them. And some days, God's on her side, and other days she's in the hospital. And that's when it's this siloed, non-coordinated care. I mean, that's a little extreme, but when they're at their best, and when, sometimes, there are those things where you need to go to a true centers of excellence, not a self-proclaimed centers of excellence. Guess what? I would trust my doc, my parents' doc, who's treated many people with Parkinson's or other issues that people have, and then get them there. And again, everybody doing the best work they do at the top of their license. It's a great team effort, and they can be the proceduralists that they want to be.
Could we, before we leave this topic, because I know we want to get into pharmacy and wellness before we're done here, I want, one of my favorite bright spots in the book is around the Orthopedic Surgery Center, and could you give folks a little bit of an understanding about this organization and why what they're doing is sort of making healthcare better?
Yeah, you're talking about Surgery Center of Oklahoma.
Yeah.
I mean, they're disruptors for sure. I mean, you go to Surgery Center OK for Oklahoma.com. They have all their prices bundled. They guarantee outcomes. If there's complications, they'll basically warranty it. And in the years that they've been doing this, which is about a decade, they've only changed their prices 4 times, and each time they went down. And you ask Keith Smith, who's the CEO there, why did he do this? Like, well, our costs went down. The inputs went down, so we lowered the price. He's not doing this as an act of charity. They just run a really effective business, and provide great care. They're transparent on their complication rates, and the word's gotten out. And definitely people will travel to Oklahoma for surgery, but he's absolutely thrilled when people go to their site and use it to price negotiate with a local hospital. I mean, he had a story he told me where there was a guy that had a very high deductible plan, needed a prostate procedure, and the local hospital, they were going to charge $40,000 for it, and he found out about Surgery Center Oklahoma was going to be $3,600, so less, 90% plus less. And he's like, I got a $10,000 deductible. I can't not go here. So he went to, told his surgeon, hey, you know, I got to go somewhere else. And the surgeon wasn't getting that money. And so he raised hell. And guess what? The hospital dropped their price to $4,000 from $40,000, which shows you how arbitrary the pricing is. And so they love doing that. And there's a whole movement they call the Free Market Medical Association of folks like this who are fully transparent, on their prices. And he's just kind of leading the charge on that.
I love it. I love it. I mean, when we have more time, I'd love to peel back like how we could take that and copy and paste it around this country, because there could be one in every state, some states too, and we'd be just so much better off, especially in orthopedics, right?
Yeah.
I want to. This is going to be a complicated one, but I think it's a really interesting question. And one of our listeners, Ferris Taylor, you're going to have to keep me, Ferris, honest if I'm reading this correctly. But this is going back to the Alaska case study or bright spot. So here's the question. So Ferris has visited the South Central Foundation in Nuka multiple times. He's been to some of those villages, 250 miles from Anchorage with no roads in it. And in addition, he thinks, in addition to the incredibly creative and mainly virtual primary care model, some of their cost savings is because IHS Hospital across the street has decided they can't continue to build facilities. And so physicians now have to collaborate with the foundation to optimize primary care. Okay, so that's the setting. Why can't we duplicate that model in the lower 48?
We can. There's a number of examples. One of the ones I like is in Eastern Idaho. It's a fairly rural area, also like Alaska. And there was a benefits consultant that partnered up with the hospital and said, hey, we can't afford, what's doing, like what's going on here for our employers can't. Let's work together. Let's get rid of some middlemen. And they essentially came up with a program that made it very affordable for them. And so employers weren't going to send their employees an hour away to another hospital. They could keep that local. And so you're starting to see that kind of collaboration. That organization has essentially created a business. I think it's called Health to Business. And the two is what the number two, where they're partnering hospitals with employers. So that's mainly in the employer arena, and so that's happening for sure there. I know they've got activity in Ohio, St. Louis, Texas, a number of different states. So it is happening. Needs to happen more. Needs to happen faster, but it is definitely happening.
All right, another excerpt from the book that is going to be, not controversial, but provocative.
Yep.
So here we go. Al Lewis, former workplace wellness industry proponent turned leading critic, offered a $3 million reward to anyone who could prove that the wellness industry has reduced employers' medical claims costs enough to cover its $8 billion annual cost. So far, his money is safe, end quote. So how would you advise us all to think about wellness programs? In fact, should we even get rid of them altogether?
Well, I will separate wellness, which is a good thing. I eat well, I exercise, I manage stress, avoid, you know, toxins and for that matter, so does Al. The time I met him in person, he biked over the Boston Common. Um, and so it's not that wellness is a bad thing. It's how we've crafted them as often a distraction where wellness isn't bad. And in fact, even some of the wellness programs are fine, and they might be good for a number of reasons, but you wouldn't necessarily do them from an ROI perspective. What Al does and what his challenge is put out there is kind of say put up or shut up. Like if you actually believe the numbers, and he dissects them, that a lot of these return on investment calculations are mathematically impossible. And that's why he's so confident in putting out that challenge there for folks. And so it's just being mindful of what actually works. Why would you do it? There may be reasons to do a wellness program that's not about the bottom line. But then again, I would argue rather than getting at the root cause of a lot of issues, what we see year to year is different distractions from the core issue that are so-called solutions. It's like, oh, your workforce is fat. Let's have a wellness program, and we'll have, these greatest loser challenges that are actually put people, in harm by having radical weight loss, rather than going, no, actually the reason premiums are going up is we're paying more than we should for hospitals, we're paying more for drugs than we should, or we're not having proper primary care. And we've seen that with, so-called transparency tools. Not like transparency is bad, but like they don't get used, and they like give you the best sucky price you might get versus actually something that's actionable. High deductible plans, again, put skin in the game. I mean, now we got kidney in the game for members, where the working middle class hasn't seen a raise in over 20 years, not because doctors and nurses are getting paid radically different. It's just we're getting price gouged. So let's just focus there, and not get distracted by something that in some cases can be good. I mean, I love healthy food. I love, gyms at workplaces. I've had those things. Nothing wrong with that. But you're not going to generally do that on a ROI basis, because most of the spend that happens is a very small percentage of your workforce who wellness programs will not change a preemie baby or a cancer or these other things. You want to get them to high value places, and the wellness program won't impact that.
By the way, I'm live in an intermittent fast as we speak on the show. So,
All right.
let's get into price gouging, and let's get into one of your favorite topics, and that's we'll call it the medicine distribution industry, or the PBM space, as a well-known huge contributor to healthcare costs. So, are there payers or employers who have taken an innovative approach to better managing this huge cost cow?
Lots of examples. Caterpillar hasn't seen overall healthcare costs go up in over a decade just by tackling drug spending. State of New Jersey, $1.6 billion with a B, $1.6 billion in 3 years saved. More smaller organization, Pacific Steel, 750 employees. It was a combination of getting smart on their drug spending and not accepting price gouging anymore, that took their spending from over $8 million on health benefits 4 years ago to under $3.5 million, while benefits improved. And the mindset shift, kind of what I talked about with Harris Rosen, happened with Pacific Steel, is they said, our employees are our most valuable asset. Every CEO says that. Healthcare industry, it is a privilege for you to serve our most valuable asset. Like everything that we procure, we are going to procure for value. And these are our requirements for how we're going to procure, just as Boeing would, spec out the jet engines that they need for their Dreamliner. If you, healthcare industry, would like to participate in that, we'd love to see your bid. And boom, they do it. What we normally have is the supply centric industry that's like, take it or leave it, employers suck it up. And they just didn't accept that. And so there's certain transparency around ingredient costs. And I mean, there's 32 different revenue streams that PBMs have generated for themselves that most employers might think that there's one or two. It just gives you an idea of how off the rails it is. And so I actually just heard a anecdote in the last week from somebody who was head of government affairs for one of the large three PBMs. And he was in the office of the general counsel. There was like a 4 to 5 inch thick contract on the general counsel's desk from a Fortune 5 company. And they were kind of yucking it up that that company, seemingly sophisticated, didn't have a prayer. They have so many little trap doors and tricks in that agreement, like they don't have a prayer. And so you can't start with their agreements. You have to start, and that's what state of New Jersey did. That's what Pacific Steel did. Caterpillar went even further of saying, we're going to commission academic research to see what is going to be in our formulary. And they went disease category by disease category. It's like, we know supply chain. We know that, we're just going to apply it in this area, and with incredible success.
That's great. Have one more question for you. Just a reminder to everyone to fill out that survey. I also want to give out a final shout out and thank you to the folks at Revel Health who helped make this episode possible. And if you are watching, listening to today's episode and want your organization to get involved in bright spots in healthcare programming, again, please reach out to me and we could chat. eglazer@sharedpurposeconnect.com. So Dave, where can people find you? Where else could they find the book if they want to pass along an option for a hard copy to friends and family around the holidays, work colleagues?
Yeah, definitely. Well, healthrosetta.org is our site for our organization and movement. I'm at Chase Dave on LinkedIn, on Twitter. You can Google me. I'm not the Sopranos producer, so I'm pretty easy to track down. And you definitely can go to our site and find more information and sign up for newsletters. When the offer we made on the book, you will receive a series of emails that will expand on each chapter and more background information, more case studies, more data. And we invite you to share that around, and we're just trying to get the word out. The books are on Amazon. I don't think the last book is on indie booksellers yet, but it will be. The others are there. So our site points you to where you can get the book, but you can download it for free as well.
The title of the book, in case you didn't write it down at the beginning of the show, is Relocalizing Health. The future of healthcare is local, open, and independent. And there's a great shot of it. Dave, thanks so much. Thanks for everyone for taking the time. I know we expanded this to 90 minutes. I wanted to make sure we were not rushed. So I think this worked out nicely. You got 20 minutes of free time on your hands, if in fact you did block the 90 minutes. And we will see you next week when we talk about, we have 2 weeks from now, I beg your pardon, we're going to have a great health plan roundtable on the consumer experience moving into 2021 and 22. So thanks everyone for listening. This marked the end of the show. Hey, Dave, hang on. Bear with me here.